E ora il turno del dottor Costea del Cincinnati University Hospital, il cui compito sarà quello di discutere i modi per tenere in pugno il ritmo del cuore. Alex, grazie.
Thank you. Mr. Chairman, dear colleagues, it's a pleasure to be here. I would like to start by thanking Dr. Pataretti and Dr. Gronda for this invitation, and also for the topic that I have received. I will have to say that for a simple electrophysiologist who spends most of the time in the electrophysiology lab, a lot of data that I heard here today was very impressive. And it actually gives us hope that we'll be able to collaborate with the heart failure teams just as well as we had in the past. As this is one of our last talks for the symposium, I thought I should start with a clinical case and get some ideas from our colleagues in the audience. So this is a 55 years old lawyer, actually, who was diagnosed with endocarditis about 10 years before, ended up having a mitral valve replacement, and developed atrial fibrillation of persistent type. Thank you. So developed atrial fibrillation with non-ischemic cardiomyopathy with an ejection fraction of 30%, followed by a bi-VICD implant. He was controlled for his atrial fibrillation with amiodarone, and between amiodarone and the bi-VICD, his ejection fraction improved to 50%. Unfortunately, he had 2 more bouts of endocarditis that led to 2 more mitral valve replacements, an aortic valve replacement, as well as the extraction of the bi-VICD. After all these procedures, so a total of 3 open heart surgeries, he developed the NYJ class 3 and hyperthyroidism leading to discontinuation of amiodarone. So we have a patient with significant non-ischemic cardiomyopathy with a lower ejection fraction, again in the 30s, and persistent atrial fibrillation where we cannot use amiodarone. What would you do in this situation? Would you consider reimplantation of the bi-VICD and use dofetilide instead? Would you consider placing an epicardial bi-VICD and perform an AV node ablation as the patient had a slightly higher than normal heart rate? Would you consider implanting a subcutaneous ICD and perform rate controlled? Or maybe will you send him to our colleagues and have an atrial fibrillation ablation performed? In the interest of time, I will not ask our colleagues to raise hands for 1 through 4, but we will come back to the answers of these questions at the end of the presentation. As most of our colleagues presented, and we already know this data from many trials, both atrial fibrillation and congestive heart failure are a very significant healthcare problem. They have a similar incidence of about 25%, and they pose significant problems of treatment and management, especially when they're combined together. The Framingham Heart Study showed that on almost 1,500 patients, there's a strong association between the 2 diseases with an almost 40% chance of overlapping and going from one to another. I apologize for this complicated slide, but this is basically showing what are the risk factors for developing atrial fibrillation in congestive heart failure. So there are ion channels and gap junction remodelings. There's a mechanical remodeling based on the stretch and increased atrial pressure, and there's a neurohormone activation that plays an important role. All these processes evolve and lead to triggered activity, reentry automaticity, ultimately AF, ultimately worsening of the heart failure. These are some specimens that I found to be very interesting from canine models of normal dogs, basically, dogs that acquired heart failure because of RA pacing, and dogs that acquired heart failure and atrial fibrillation because of RV pacing. As you can notice, when the 2 diseases are combined, there's a significantly higher degree of fibrosis. As electrophysiologists are interested on where this fibrosis is and what role does it play in the perpetuation of arrhythmia, another animal study that was recently published showed that this fibrosis is mostly distributed in the posterior wall. There's a direct correlation with the fractionation of the potentials that are recorded in that area. But what's very interesting is that the more fibrosis you have, the more organized the arrhythmia is going to be, which is somewhat unexpected because you think if somebody has persistent AFib, there's a lot of disorganized activity. Well, it turns out that the cycle length is longer, and there's a more organized waveforms that are recorded. In terms of the clinical consequences of atrial fibrillation, most of us are very familiar with them, less the electrophysiologists and the heart failure specialists, of course, but loss of organized activity, impaired ventricular filling, irregularity of ventricular contractions lead to a drop in the cardiac output with up to 30%. Therefore, it is very important to address these patients appropriately, and there are basically 5 lines of therapies that are very important. I will not talk about the thromboembolic risk because this was presented before. But initially, people have looked, of course, at the rhythm control or rate control for these atrial fibrillation patients. And unfortunately, this is moderately successful, with studies quoting success of 20 to 60% at most. When looking at what's better, rhythm control versus rate control, specifically in patients with congestive heart failure, about 1,500 patients, again, followed for about 3 years, showed that there's basically no survival benefit if you choose one versus another. Conversely, there are some other trials, especially the trials that were published around the new antiarrhythmics, specifically dofetilide, that showed a reduction in heart failure occurrence if these patients with atrial fibrillation are using this medication. In terms of the renin and angiotensin system and axis, these have been touched on previous talks, but meta-analysis done on 56,000 patients with 11 trials being included, most of them being on heart failure and hypertensive patients. It's been noticed that ACE inhibitors and ARBs are reducing the atrial fibrillation by 28%. This benefit becomes major, up to 45% risk reduction of atrial fibrillation when these patients also have heart failure. Addition of beta blockade further decreases the risk to about 27%. So this is an important line of therapy that should be considered, and it is used in patients with heart failure anyway. Now, what can we do in terms of interventional approaches? And basically, this is what we're interested in. Initially, as the heart rate had been difficult to control, and patients' compliance are sometimes issues, or blood pressure tolerance to all these medications can become an issue. A therapy has emerged and consists of ablating the AV node and inserting a biventricular pacemaker or a biventricular ICD. And there is significant data. This is only one of the trials that showed on 250 patients that there's actually a survival benefit if this approach had been chosen. So we're getting to the more interesting part of the talk, and I think Dr. Padaletti will elaborate on this a lot more, but the atrial fibrillation ablation is actually one of the solutions that we're very excited about. Now, we won't see as large as a trial as we saw in heart failure or in high blood pressure because there's not a lot of data on how effective this procedure is. But as early as in 2004, there were 2 important studies, one coming out from the Michel Hassaguer's group in Bordeaux. They matched about 60 patients with atrial fibrillation and ejection fraction of less than 45% and atrial fibrillation alone, and performing pulmonary vein isolation and additional lines during the ablation. They followed the patients for 12 months, and they showed an improvement in the ejection fraction, in fraction of shortening, and other important parameters. So you can see here some graphs where up to 12 months, there's a preserved benefit in the improvement in ejection fraction of patients who received ablation as compared to the ones who received medication. The same applies for the LV and diastolic volumes and LV and systolic volumes. One important conclusion of this study was that not everybody benefits from an atrial fibrillation ablation. So as early as 2004, it became obvious that if someone has concurrent heart disease, i.e. coronary artery disease, or if somebody has an adequate rate control, they will not benefit from the atrial fibrillation ablation. The second trial that was published in the same year, this time from Dr. Natale's group at the time at Cleveland Clinic, was done on 94 patients. Importantly, they performed only pulmonary vein isolation and defragmentation of the posterior wall. They followed the patients for 14 months and noticed that there is an increase in the ejection fraction, although not statistically significant. They did notice that there's, of course, a higher risk of recurrence and there's a better quality of life. So in the end, it was a suggestion of a positive study, but not reaching statistical significance. Now, 10 years later, we're lucky enough to have enough data and long enough follow-up, again, still small trials, but For example, this one was just published last month on 69 patients with less than 40% ejection fraction. This is a group in Germany. They were followed for 3 years. They had 60% maintenance of the normal sinus rhythm after multiple ablations, so not just one. And they noticed that there's a long-term ejection fraction increased and a similar improvement in NYHA class. This was statistically significant. And the improvement was noticed 6 months and beyond. Again, two specific classes had significant improvement. Patients without coronary artery disease actually did better in terms of improvement of ejection fraction, as well as patients with persistent atrial fibrillation. This is no, I'm sorry, I thought I didn't move forward, but it seems like I did. It's Dr. Gronda's fault for the dinner last night. This is another long-term follow-up study on 196 patients this time. 77% had persistent AFib, so again, high-risk patients with persistent atrial fibrillation. They were followed for as long as 4 years with 30% reablations. This is a relatively optimistic number, I would say. They maintained sinus rhythm, and in those patients who maintained sinus rhythm, the NYHA class has improved, the ejection fraction has improved, and the mitral regurgitation has decreased. What's important to note here is that there was a comment about how reliable is the echo reading when you perform an echocardiogram in patients in atrial fibrillation versus when you perform it in a normal sinus rhythm. So some artifact could have been induced there. Now, how do we compare this with the previous two therapies that we talked about? Well, in terms of medical therapy, another recent study coming out of London showed for a follow-up of 6 to 12 months that atrial fibrillation is superior to pharmacological therapy. So not only did they show an improvement in ejection fraction and other echo parameters, but they also showed an improvement in Minnesota Living with Heart Failure score, which is basically this graph here. As you know, the lower the score, the better it is. So this was not only echo improvement, but functional results as well. When it comes to comparing this with the blatant PACE approach, 40 patients were randomized to pulmonary vein isolation and ablation versus AV node ablation, and it was noticed again that patients who had AV node ablation did not improve their ejection fraction, while those who had atrial fibrillation ablation did. Same thing for the 6-minute walk test, so again, a functional test that showed a better result. And as we all know, when you perform an atrial fibrillation node, AV node ablation and a BiV-ICD implant or BiV pacemaker implant, you do not restore the AV synchrony. Now, this is a trial that still is being published, I guess. It started in 2008. They enrolled a significant number of patients. The benefit of this study is that everybody had an ejection fraction less than 35. They had an ICD implanted already, so therefore very accurate recordings of recurrence of atrial fibrillation or not, and they were randomized to standard therapy versus atrial fibrillation ablation. Because the follow-up has been set at 3 years, I think the study has not been published yet. So reviewing the literature that we have available, and again, it's not a lot of literature on atrial fibrillation ablation in heart failure, there seems to be several groups of patients who will benefit from this approach. So if you have someone with a diameter of the left atrium less than 6 centimeters, if they have a suboptimal rate control and the baseline heart rate above 93 in persistent AFib is considered one of suboptimal rate controls groups, I guess. Failure or intolerance to antiarrhythmics, patients with persistent AFib or non-ischemic cardiomyopathy, patients with no wall motion abnormalities of echocardiogram. These are patients who would benefit from an ablation, or at least should be considered for an ablation. So going back to our clinical case, would you reimplant the BiV-ICD and use dofetilide? We chose not to reimplant this as the patient had 3 episodes of endocarditis, and therefore there would be a high risk of reinfection for sure. Did we perform a subcutaneous ICD and rate control? He's a young patient. He would not benefit from resynchronization. There was a proven benefit of him being in sinus rhythm and resynchronized, so we didn't choose this approach. Epicardial BiV-ICD and AV node ablation, again, this was a therapy that commits somebody to continuous support from pacing, and also the epicardial BiV leads are not that reliable, so we did not choose this approach, and therefore we performed an atrial fibrillation ablation. These are some carton maps that I acquired before the ablation was initiated. And as you notice, the red areas are scarred areas. On the PA view, you notice that there's a lot of variability in the voltage amplitude. The pulmonary veins are almost isolated, which is basically something to be expected in somebody with a persistent atrial fibrillation. After the ablation, we surrounded the pulmonary veins and we performed a lot of ablations chasing different arrhythmias on the posterior wall, which again goes along with the study about the location of the fibrosis. This is basically how we started. You can see there's a very fragmented signal in the coronary sinus. As we continue to ablate, the cycle length has changed, and we were eventually able to terminate the arrhythmia. Now, probably because he is a lawyer and because I'm very happy, I'm very lucky, I guess. He stayed in a normal sinus rhythm for 9 months, and his EF has improved from 30 to maybe 39%. So probably next year I'll tell you his ejection fraction is 75%, but we'll see. Thank you very much.
Thank you, Alex.